Okay, so when we think about light therapy, it feels really cutting edge, doesn't it? Like something straight out of a lab.
Yeah, very modern.
But get this. Ancient Egyptians, we're talking around 2000 BC, were actually using sunlight combined with an herb for vitiligo.
Wow, 2000 BC. That's incredible.
And it doesn't stop there. In the 1800s, you had doctors trying red light for melancholia.
Melancholia, huh? Interesting term.
And even prescribing just natural sunlight for serious stuff like tuberculosis and rickets.
It's fascinating, isn't it? This kind of persistent idea across centuries that light does something, that it has some kind of healing power.
Exactly, like an intuition.
Yeah, even without the detailed science we have now, they just sensed it somehow. It makes you wonder what else we kind of intuitively get that science is still catching up on.
Totally. And those hunches, they really started to get, scientific with some key moments. Like Niels Finsen, early 1900s.
Finsen, the Nobel Prize winner.
Right. He built this electricity-powered phototherapy device, and it worked against skin tuberculosis. That's huge.
Monumental, really. And then fast forward to the 50s.
The blue light for jaundice in babies.
Exactly. A total chance discovery, apparently, but it saved lives.
Yeah.
Showed how specific light could be.
Right. It wasn't just light anymore. It was witch light. Different colors, different effects.
Precisely. The wavelength started to become really important.
And then, 1960, bam!
The laser.
The laser arrives.
Yeah.
That must have changed the game entirely, offering this incredible precision.
Yeah, absolutely. And then later that decade, you have Mester.
Mester, right. He found something counterintuitive, didn't he?
He did. He discovered that low levels of laser light that didn't even generate heat, could actually reduce inflammation and pain. A thermal effects.
So not burning or cutting, but something else. Modulating.
Exactly. Modulating biological processes. That realization that light could heal without causing damage, that was, revolutionary. It opened up a whole new way of thinking.
Which brings us towards, modern low-level light therapy, or LLLT. And then, surprisingly, NASA gets involved in the late 90s.
Yeah, NASA's contribution was actually pretty critical. They developed these really powerful, specific LEDs. Quasi-monochromatic, they called them.
Quasi-monochromatic, meaning very specific color.
Very narrow band of wavelengths, yeah. And they had the power needed, the intensity, to make LED-based LLLT a practical medical tool, not just a lab curiosity. More versatile than lasers in some ways.
Okay, so that's quite a journey. From ancient Egypt to NASA LEs.
It really is.
And that sets the stage for our deep dive today. We're looking at an article by R. Glenn Calderhead, focusing on the science behind what he calls multi-specialty LED-LLLT.
Right, getting into the nitty-gritty of how it actually works.
So boil it down for us. What's the absolute core principle of this LED-LLLT?
Okay, at its heart, it's about transferring energy. Light energy, photons specifically. These photons are absorbed directly by cells.
Absorbed by cells.
Yeah.
But
Crucially, without significant heating. It's a thermal, like Mester found, and atraumatic. No damage. Think of it like giving the cells a direct energy top-up. Boosting their function.
Okay, so not blasting them, just nudging them, helping them work better. And Calderhead mentions 3 main ways this light energy can affect the cells.
That's right. 3 potential outcomes. First, if a cell is compromised, maybe struggling a bit, the light energy can help repair it, kind of kickstart its own repair mechanisms.
Okay, repair. What's the second?
Second, if the cell is already functioning okay, the light can actually make it work more efficiently, like fibroblasts, the cells that make collagen in your skin. They might get a boost and produce more.
Right, making healthy cells work harder, basically.
In a good way, yeah. And third, LLLT can sometimes encourage cells to move to where they're needed, or even to multiply. It's called photochemotaxis.
Photochemotaxis, so light-guiding cells. Interesting.
It is. So repair, enhanced function, or proliferation and movement. Depends on the cell and the context.
So it's definitely not a one-size-fits-all beam. But, I mean, you can't just shine any old flashlight on yourself and expect these results, can you? The wavelength has to be critical.
Oh, absolutely critical. Probably the most critical factor. The wavelength determines 2 main things.
Okay.
1, which specific molecules inside the cells, called chromophores, will actually absorb that light. And 2, how deep that specific wavelength can penetrate into the tissue.
Absorption and penetration depth.
Got it. And of course, you need enough intensity of that right wavelength to actually make something happen biologically.
Right. Makes sense. Which leads us nicely to figure 1 in the article. It's a graph, a photospectrogram.
Yeah, showing light going through a human hand.
It really illustrates that penetration point.
Yeah.
Can you walk us through what we're seeing there?
Sure. So the graph shows something called optical density, OD. Think of it like how much the tissue blocks the light. High OD means poor penetration.
Okay, high OD, light doesn't get through easily.
Exactly. And you can see for the shorter visible wavelengths like 415 nanometer blue light or 590 nanometer yellow, the OD is really high. They get blocked quite a bit.
So they stay pretty superficial.
Very superficial. But then you look at 633 nanometer red light, the OD drops significantly. It penetrates much, much better.
Noticeably better, yeah.
And then the real star performer for depth is the 830 nanometer near-infrared light, NIR. Lowest OD on that chart. It goes the deepest.
Okay, so blue yellow shallow, red deeper, near infrared deepest. That variation is huge.
It really is. And it directly informs which wavelength you'd choose for different targets in the body.
Which is why Calderhead argues that an ideal LED-LLLT system needs to offer, what, 3 specific wavelengths?
That's his position, yes. Based on that science, he highlights 3 key ones: 415 nanometer blue, 633 nanometer red, and 830 nanometer near infrared.
Blue, red, and NIR, because they hit different depths and different targets effectively.
Precisely. Each has its own kind of therapeutic sweet spot.
All right, let's break those down then. Start with the shallowest, 415 nanometer blue light. Penetration is only about, what, 1.5 millimeters?
Yeah, pretty shallow, but that's actually perfect for its main job.
Which is?
Targeting a specific bacterium, Propionibacterium acnes, P. acnes, the main culprit in acne vulgaris.
Ah, okay. So how does blue light get rid of bacteria?
Well, P. acnes naturally produces these molecules called porphyrins, and these porphyrins just happen to strongly absorb 415 nanometer blue light.
Okay.
When the blue light hits them, it activates the porphyrins, and they start producing reactive oxygen species, basically oxidative stress, inside the bacteria.
So the bacteria's own molecules turn against it.
Exactly. It triggers cell death, apoptosis in the bacteria. It's like an endogenous photodynamic therapy, or PDT, using the bacteria's own stuff to kill it. Very targeted.
That's clever. Very neat. But the article mentions a possible side effect, particularly in Asian skin types.
Right. Because blue light is still visible light, the pigment cells in our skin, melanocytes, can sometimes react to it. They might see it as a potential stressor and ramp up melanin production.
Leading to darkening.
Yeah, potentially some temporary skin darkening.
Right.
But interestingly, Calderhead points out research showing that if you combine the 415 blue light with either the 830 NIR or the 633 red, that can actually help prevent that darkening effect. Plus, those other wavelengths help with inflammation and healing anyway.
Yeah.
So combining them offers kind of a synergistic benefit, mitigates the side effect, and helps the underlying issue.
Fascinating. So the wavelengths can work together, even counteract potential downsides. Okay, let's move deeper. 633 nanometer red light penetrates more than blue. What's its main use case?
So 633 red has been looked at for skin rejuvenation and wound healing too, but its primary role now, clinically, is often as a photoactivator for exogenous PDT.
Exogenous, meaning from the outside.
Exactly. This is where you apply a cream or gel, usually containing something called 5-ALA aminolevulinic acid. The target cells, like non-melanoma skin cancer cells or precancerous cells in actinic keratosis, absorb this 5-ALA and turn it into porphyrins, just like the acne bacteria have naturally.
Ah, so you're artificially creating the target molecule in the bad cells.
Precisely. Then you shine the 633 red light on the area. Because it penetrates deeper than the blue light, it can reach these slightly deeper skin cancers or lesions and activate those porphyrins you just created.
Same mechanism as the blue light then, activating porphyrins to kill the cells.
Same basic principle, yeah. Oxidative stress leading to cell death. But here, the light is just the trigger for the drug you applied, and it's gentler than some other activation methods.
So 633 red is mainly used with a topical drug for things like basal cell carcinoma, Bowen's disease, actinic keratosis.
That's a major application. Though the article does also mention some studies showing benefits for active acne and skin rejuvenation just using the 633 light on its own.
Okay, and hair loss too.
Yeah, there's some research suggesting it might help with androgenic alopecia, potentially even boosting the effects of treatments like minoxidil. The deeper, gently activation seems suited for these kinds of targets below the immediate surface.
Right. Okay, finally, the deepest penetrator, 830 nanometer near infrared. NIR. This one sounds like a real workhorse.
It really is. 830 has a long history in LLLT, even back in the laser days. Calderhead highlights a key 2007 study that directly compared 830 NIR, 633 red, and a combination for skin rejuvenation.
And what did they find?
Well, 830 showed significant benefits, but they also looked at how the histology, the effects on wound healing processes at a cellular level. Another study mentioned looked specifically at how 830 affects mast cells, potentially speeding up wound healing by modulating their degranulation.
Mast cells. Those are involved in inflammation and healing, right?
Exactly. And the list of applications for 830 is, well, extensive.
Yeah, the article mentions wound healing, acute, chronic, traumatic, post-surgical.
Yep. Pain relief, acute, and chronic.
Bone repair, nerve repair.
Sports medicine injuries, hair regrowth. It's incredibly versatile because it can reach so many different tissue types effectively.
And a really interesting point was its use after other procedures.
Oh yeah, that's a big one. Using 830 NIR as an adjunctive therapy after aesthetic treatments like lasers, peels, even surgery.
Why do that?
It significantly reduces downtime. Less redness, less swelling, less discomfort, and it seems to improve the overall results of the primary procedure too. Calderhead cites work showing this quite clearly.
So faster recovery and potentially better outcomes. That's a huge plus.
Absolutely. And it's also used for general skin aging, either by itself or combined with other things. It just has this broad pro-healing, pro-rejuvenation effect deep in the tissues.
Okay, so these three wavelengths, blue, red, NIR, each have their specific roles based on penetration and targets. Now, the article talks a lot about a specific system, the Light 2. It presents it as kind of embodying this true science of LED-LLLT. What's special about it?
Well, fundamentally, it incorporates those three key wavelengths we just discussed. 415, 633, and 830. So it meets that multi-specialty criterion.
Okay.
But beyond that, it has two unique technologies that Calderhead emphasizes as being really important for efficacy.
All right, let's get into those. The first is called optical lens array technology, OAA.
OA, yeah. So the problem with standard LEDs is that the light they emit spreads out, it diverges.
Like a bare light bulb versus a spotlight.
Exactly like that. As the light spreads, the intensity drops off quickly. You lose photons sideways, basically.
So less energy actually reaches the target tissue deep down.
Right. OLED tackles this by putting a special lens, a semi-collimating lens, right in front of each little LED chip.
What does that do?
It gathers that diverging light, focuses it, minimizes the side scatter, and projects a much more concentrated, higher intensity beam towards the skin. Figure 3 in the article shows this quite well. The difference is pretty dramatic.
So OLED means more photons delivered more efficiently to the depth you want them to reach.
That's the idea. More bang for your buck, photon-wise. It allows therapeutic levels of light to reach deeper tissues more effectively than systems without that kind of focusing.
Okay, that makes a lot of sense technologically. More focus power. What's the second unique technology? It's specific to the 830 head.
Yes, this one's called photosequencing technology, and it's specifically in the 830 nanometer NIR head. It's a bit more complex. Okay, so the 830 head has arrays of LEDs, mostly 830 nanometer LEDs. But in specific spots, figure 4 shows it. It's a fourth LED. And from each end of the rows, there are special double chip LEDs.
Double chip, meaning?
They can emit both the main 830 millimeter NIR light and a lower intensity 590 millimeter yellow light.
Ah, okay. So you've got mostly NIR LEDs and then these few special ones that can also do yellow. How does the sequencing work?
So when you start an 830 treatment, for the very first minute, only the 590 yellow component of those special LEDs lights up. And they do it sequentially, scanning across the panels. Each one lights for about a second.
The little yellow light show for the first minute. What's the yellow light doing?
Well, 590 yellow light, remember, is more superficial. It mainly targets the epidermis, hitting cells like mother keratinocytes and Merkel cells, which have lots of mitochondria.
Those power plants.
Right. The theory is that this brief sequential yellow light exposure kind of preconditions the epidermis. It stimulates those mitochondria, increases extracellular ATP and calcium signaling, basically making the surface environment more receptive or optimized for the main treatment.
Interesting, like prepping the surface. So what happens after that first minute?
After minute 1, boom, all 1,800 of the main 830 nanometer and IR LEDs switch on, delivering that deep penetrating therapeutic light.
Okay.
But the 590 yellow LEDs continue their sequential scanning pattern while the powerful 830 light is on.
Why keep the yellow going if the strong NIR is on?
Good question. Clinically, the effect of that low intensity 590 is probably negligible once the much more powerful 830 kicks in, but 830 NIR light is invisible.
So you wouldn't see anything.
Exactly. The patient wouldn't know if the machine was even on. So, keeping that visible 590 yellow light cycling across the panel provides a constant visual reassurance that the treatment is active and ongoing.
That's clever. So it's partly psychological reassurance, but based on that initial epidermal preconditioning idea.
Yeah.
And the overall effect targets both epidermis and dermis.
That's the concept, a dual depth benefit plus patient comfort.
Okay, so recapping the Helite 2 as the example system.
Yeah.
It's got the 3 core wavelengths. It uses OLAT for focus delivery and this photo sequencing with the 830 head. Calderhead argues this combination makes it safe, effective, reliable for a whole host of things.
That's the conclusion presented, yes.
Yep.
And that its versatility makes it useful both on its own, or maybe more often, as an add-on to other treatments in lots of different medical settings.
Right, aesthetics, plastic surgery, general practice, physio, sports med.
Pretty broad range of potential users.
So we've definitely taken a deep dive into the science here. It's clear that LED-LLLT, when it's done right, based on these principles, it's far more than just shining a light. It's really specific.
Absolutely. Wavelength specificity, sufficient intensity, targeted delivery. These are key. It's a sophisticated modality grounded in photobiology.
When it's based on that solid science, it really does seem like a valuable tool with, wow, a lot of applications.
Yeah, a surprisingly wide range, from wound healing to pain to skin health.
It really makes you think, doesn't it? Light itself, so fundamental, so everyday, being harnessed in this incredibly precise biological way to help us heal and, function better.
It's pretty amazing when you break it down.
It kind of leaves you wondering, what other basic, long-understood things around us, like light, might hold similar scientific secrets? Other phenomena just waiting for us to figure out how to apply them in completely new, beneficial ways.
That's a great question to ponder. What else is hiding in plain sight?
Maybe something for you to reflect on after our dive today.